Welcome up to stage Dr. Jaron Chong. Dr. Jaron Chong is an assistant professor at the Department of Radiology at McGill University. He completed diagnostic radiology residency training at McGill University with an abdominal imaging fellowship at Yale New Haven Hospital and a master's in health informatics at the University of Toronto. Welcome.
Oh, thank you so much. Hello, good afternoon, everybody. I understand we're reaching towards the end of the day, so I'll try to keep this very pointed. Now, the title of this talk is Training Radiology Residents When Machines Read Imaging. I received this explicit title as the title of this talk, and the thing is, though, I'm a card-carrying radiologist, right? So there's a certain premise that has to be assumed here regarding specifically this talk. So this talk, by its very nature, as Jaron, if you were at the talks yesterday, right, is a controversial talk, right? I'm a radiologist, and I'm going to be speaking about machines reading imaging. So the first thing I wanted to point out, is that at some point you have to analyze the premise of this, right? So I don't know exactly when this could theoretically occur. So this is I put a science fiction slide up, right, in the year 20XX, when this is actually going to occur. And this premise of us being able to stay, in our dark rooms, talk to ourselves, read these images and so forth, right? It really depends upon what the definition of read is, right? This is my Bill Clinton moment as well too, right? So, and I considered different strategies when trying to figure out what to do with this talk, right? I figured, maybe I would say it's not realistic, but actually I thought it would be a little bit more interesting to advance the premise, okay? So I think the discussion afterwards is gonna be more interesting. We advance to a full Skynet premise. So basically, what the premise that I'm gonna be operating under is, number one, detection. The machine, given a specific indication, the modality, a body part, a location, is going to be capable of analyzing a study, can locate and diagnose abnormalities, or guarantee normality to a clinical standard. Number two, it can integrate. So therefore, it will be able to integrate study information, EMR information, and also augment with contextual information. Number three, it's going to be able to report. The machine, using standard templates, will draft a full report equal or superior to current clinical practice, plus minus maybe even a multimedia report. It'll do a better job. This is the premise that I'm going to run the rest of the discussion under, and I think it's going to be very interesting what comes next. And this is obviously not just going to impact this premise, at least. It's not going to impact resident training. It's actually a existential question for the specialty, right? It's going to impact across the timeline, across all potential practitioners of radiology. So, given that, operating from first principles, potential responses from a radiology or from a specialty perspective, right? You can think really about it. This is the way I've decided to think about it, right? Along three ways, right? You can do absolutely nothing. That's one response. Maybe that's the null hypothesis response. You can reinforce scope. What I mean by that is that if we consider that any specialization in any task is heterogeneous, there are some things that are more AI resistant. There are some things that are more AI conducive and so forth. And so can you modify a specialty or practice so that the strengths of it, the human strengths of it, are what you're gonna be able to focus on? And the last one, can you expand scope? So is there something that you can change about a specialty that will be maybe something new that the specialty did not do before in the past, but now it's gonna attempt to do so? And so if you take this this three-dimensional axis here and try to explore these ideas, you get certain possible responses, right, which I'll go into in more detail, but quality control, trying to explain algorithms, intervention versus procedures, consultations and how you play that role in multidisciplinary boards, getting full service integration, or ultimately playing a role in algorithm improvement. And let's go through some of these there. First one, quality control. It's an assumption, and I spoke on this in the previous day, that systems can be perfect, that all systems will be perfect. And one of the premises that I'm operating under actually is that there's a spectrum of performance. As many great AI systems as there will be ones that will be utterly awful, there will be ones that will be average and so forth. And so when you operate within a variety of these systems, right, there will be some element of quality control that will be necessary as well. And I think that's one major role from a physician perspective that you could actually play. So where you could see the role of a radiologist or any physician that relies using AI systems as well, is that you're going to be positioned in such a way that you're going to be monitoring, validating, trying to understand, especially the exception cases as well. There was one scenario that I had discussed in smaller groups, which is where you could imagine, and this is another assumption too, we talk about AI as though it's a monolithic system, right? It could be a heterogeneous system. So if you have multiple opinions in the room, how are you going to quality manage that, right? Maybe some systems are better in certain situations. This works well in adults. This works better in pediatric situations and so forth. So you're going to be able to need to manage and juggle that. In some respects, actually, and I remember back from training as well too with nuclear medicine as well. So the nuclear medicine as a culture, actually, they're a little bit more advanced than radiology. So as a radiologist, we're usually used to just working from front to back on the work list, right? In nuclear medicine, there's more advanced software. They use their advanced workstations a little bit better. There's more analytic curves as well too, right? And they understand a little bit more of the nuances of that. So we're going to see probably more of that within imaging. And ultimately as well too is this question of responsibility, right? I put the image there on the right, which is basically laboratory medicine. And so it's for the Canadian residency match, right? It's one of the smallest. There are very few positions for laboratory medicine as well too. Even for something that's highly repeatable as well too, there's always an element of quality control, and that still exists as a residency situation. Number 2, algorithm explainability, right? In the bottom right corner there, I think it says there, it's Lycerius Consulting, the PITIA. Does anyone recognize this or know what PITIA is, right? Probably not, okay. You might know it with a different name, the Oracle of Delphi. Maybe more people recognize this term as opposed to PITIA as well too. My one observation as a radiologist on this slide as well too, notice the lamb that's being offered as well too. So sometimes when you're trying to review a CT with one of us, right, maybe you can bring up that lamb or not. We're not going to demand that. We're not going to demand that, but I guess it doesn't help. It doesn't hurt at least. So the point that's being made from here actually is this, right? If you actually go up and look up what the Oracle of Delphi is, there's a quote here. One of the main stories claimed that Pythia delivered oracles in a frenzied state induced by vapors arising from a chasm in the rock, and then she spoke gibberish, which priests interpreted as the enigmatic prophecies and turned them into poetic, dactylic hexameters preserved in Greek literature. So I'm not saying that reports should be written like this, right? But it gives you an idea, it gives you a thought, right? Because we've talked a lot in this conference about the explainability of AI. I'm going to put to you one sentence here. What if the machine makes a prediction and nobody understands it, right? Can we see that as a possibility? Might that be, pardon me? 42, right? And then you got to spend this whole system afterwards to try to figure out what actually that meant, right? 42. There's an assumption here that, given the current models of explainability, that the answer is just going to be there, and we're actually not going to naturally trust it, right? And I can see that in a screening perspective when it says it's normal, negative, right? Okay, no, that's fine. Maybe that it's probably working very well. The ROC curve says that it works very well too, right? But what if the machine says, do a distal pancreatectomy, do a Whipple, right? And the surgeon doesn't feel quite right about it. Maybe the risk factor is a little bit off as well too. But this machine is validated, right? It's FDA approved, correct as well too. And now you're going to have to take on something very, very intense, very, very advanced, take the responsibility for it based upon the recommendations of the system as well. So who's going to explain it? Who are you going to call, right? And I'm not sure if it's going to be IBM, it's going to be Watson, it's going to be a vendor, right? I'm hoping it's going to be a radiologist, but there's this notion here of how we're going to explain it. And if you talk about one of the potential roles for a future physician as well too, maybe we might have to explain those frenzied predictions in some way as well too, make sense of it. Maybe we're going to have to integrate multiple systems together. Next point here. Interventions and procedures as well too. Obviously this is very historical, right? But I think as we said earlier, look into the whites of your eyes, right, and try to see the person that's going to put this large caliber needle into my kidney, right? So in some sense as well too, if you go back historically to let's say pre-CT radiology as well too, there was a very strong interventional component to radiology. Right, so I was told stories when I was in the second year residency. So I had a mammographer that was giving me a case, and then she used to regale us with stories of, I think, transaortic punctures for angiograms. I hear some nods of agreement there in the corner there as well too, right? So, and then we were like, whoa, this is that sounds a little bit dangerous. But it happened, right? There's an evolution of practice there. We used to use a lot more interventional and other procedures for regular diagnostic things, and you can see an evolution towards that some of the procedures, some of the hands-on components that are not as automatable, right, are going to come to the fore again. And one of the things that we often talk about, these changes that are actually occurring, they may not necessarily be instantaneous. They could actually occur over time. So there would be time from a training perspective to be able to adapt practice. We talk about consultation and multidisciplinary boards, right? So right now, if you think about it, consultations and multidisciplinary boards, they are competitive with the routine work of reporting, right? If there's a reason why you come to someone's office and they don't want to review that scan review as well too, or because there's an unread work list that's about 50 scans long and you're trying to get through that as well too. If you can imagine a future where there is some level of validated reliability regarding routine and non-routine, right? It does open up the available time. It does open up workflow and resources that you can reorient that towards probably higher value activities, more useful activities to the community that you're practicing in, that you're working within as well too. I also bring up this last point here at the end. So skills, from a trainee perspective, right, that the competencies would have to be emphasized as well. I was part of the first generation of the American Board of Radiology in which we took the fully computerized examination. This is a 2-day examination, 600 or 700, 800 questions in a row. You go in one day, you go in the next day as well too. In comparison to the Canadian Royal College examination, we maintained our oral component. It's a consultative component as well too. So you can imagine that if the examination that you've evolved to right now is fully and completely computerized, but your future role is going to be actually oral, it's going to be consultative as well too, then maybe your examination system is not quite aligned with the future of the practice of that specialty as well. And so I think that's a little bit of an interesting point. Service integration. Within radiology, probably the group that does the best job of this is women's imaging and mammography as well too, where you're really handling the full end-to-end experience of a patient. They come to the clinic, they come in for screening, right? You're doing the risk stratification, additional examinations. You're going to perform that. You're going to give some feedback early to the patient as well too, right? And so you can see models of care evolving towards that with increased patient responsibility and contact. And again, that would be something that would have to be emphasized from an educational perspective. And I left it deliberately at the end, algorithm development, right, the whole learn to code argument. And if you were at the talk yesterday as well too, I think that I would want to encourage AI literacy, not necessarily from a technical perspective, from a learn to code perspective as well too. But I think that from a structural perspective, it would behoove every specialty to actually start, maybe not requiring, but encouraging at least hybridization or forming interdisciplinary communities that will combine clinical plus technical members, right, in order to be able to participate within algorithm development. In addition as well too, we can actually even start modifying it from an undergrad or from a medical school perspective as well, right? The kinds of candidates that we bring in and try to preserve and encourage these sort of abilities. So if there are students, if there are people that are coming into the medical community as well, right? We want to create opportunities for them to be able to bring those talents to the fore in order to help medicine as a whole. And I think that the one last point at the end of this as well too is that the bar for algorithm and AI development, it is changing, it is moving as well too. So there's some keywords that are down there, AutoML, neural architecture search as well too. These are things that from a technical perspective effectively is that some of the art of machine learning and deep learning right now, where you have to select hyperparameters, you have to select what architecture, what is the best architecture and so forth, right? There is enough technical elements on the edge or the forefront of the science here, right, that maybe we can put that as part of the training cycle as well too. That has been at least proposed by some AI advocates. In response, right, you can see different axes. This is by no means exhaustive. There could be many other responses as well too, but it's just maybe one way to think about how any specialization would respond. And so if you look at implications on trainees as well too, we really do have to emphasize quality, validation, right? We have to do that at every single level, from every day, from a primary care physician to a subspecialist to a data scientist as well. I think that's extremely important, right? I think that if you're a specialty trying to respond to this, you want to position yourself as a moderator of AI with an expertise and a way and a role perhaps, right, to explain what are these predictions that are so difficult to explain. I think that could be a very positive contribution to medical care. There are probably components of your practice like procedures, like communication skills and so forth that need to be explicitly integrated into what is really around more of a soft curriculum, not really a formal curriculum. Right? And anything that you can do to increase patient contact and responsibility, anything that you can do to basically encourage talented or technically oriented trainees as well too, will be extremely beneficial for both medicine and any subspecialty at large. So there's one last point that I'm going to end on. This is a quotation, actually. You can watch this video. It's from a guy, an economist, actually, Richard Baldwin as well, that talks about the nature of AI and work. And I'm going to read it out word for word, but the future of work to me is going to be more human, because if you want to know what we will be doing, you have to look at what AI cannot do. They can't deal with unknown situations, they can't provide empathy or apply ethics or be creative or manage many people or motivate people or educate people. These are things that AI can't do. So therefore, whatever the new jobs are, and what they will appear, we don't even know the names of them, just like we didn't know in the past 2 transformations, but what we will be doing is the most human of our tasks. So, let machines be machines, let humans be human, be humane, be compassionate, put this patient at the center of your care as well too. And hopefully everything should be all good. Thank you very much, guys.